Thanks everyone for tuning in on Zoom this morning and listening to my grand rounds. I am Matthew Bo. I know I'm on Emily Stewart's account, but because I locked myself out of my own Zoom account and I can't figure out how to change it. So thanks for bearing with me. Um, so we're going to talk about systemic therapies for advanced urothelial cancer, which is really a field where there has been a lot of change in the past few years and really especially within the past year or so. So, excuse me. We're going to start off by reviewing the treatment landscape before the advent of immunotherapy. And for this talk, when I refer to advanced urothelial cancer, what I do mean is disease which is unresectable or metastatic. And this whole field has really been changed significantly with immunotherapy within the past 3 or 4 years. So just to get a baseline, we'll talk about how things were before, and then we'll start looking at how things are now and what the changing landscape looks like. We'll sort of build a treatment algorithm, starting in the first line for advanced disease, and then second line after progression on first line therapy, and then third line and beyond, and experimental therapies. And we'll go over the evidence behind all of that. So just to start off on the pre-immunotherapy era, before checkpoint inhibitors, before IO, basically if you had advanced disease, you got platinum chemotherapy if you could. For those who were eligible, cisplatin-based regimens were the mode of choice. So those were typically gemcitabine cisplatin, gemcitabine paclitaxel, MVAC, or dose-dense MVAC. For those who are ineligible for cisplatin for one of several reasons, which we'll go into later, your next best choice was gemcitabine and carboplatin. And for those who are completely ineligible for any sort of platinum, you could receive gemcitabine with a taxane such as paclitaxel or docetaxel. The original cisplatin-based chemotherapy regimen was MVAC, methotrexate, vinblastine, doxorubicin, and cisplatin. This four-drug combination gave an overall survival of about 14 to 15 months, which decreased to about 4 months if you had poor performance status or prognostic factors such as liver, bone, or lung metastases. Progression-free survival was on the order of 7 to 8 months, and the response rate was about 50%. So keep these numbers in mind because this is sort of the benchmark to which we'll be comparing throughout the rest of the talk. However, MVAC was extremely toxic and was very poorly tolerable for a lot of patients, especially advanced, urothelial cancer patients who tend to be quite sick, old and sick. And so gemcitabine and cisplatin was an alternative to MVAC that had similar efficacy but significantly less toxicity. Another alternative was adding paclitaxel to the GemCis, which gave a higher overall response rate with an absolute benefit of about 12%. Overall survival was numerically higher by roughly 3 months, but it was not actually significantly better. And of course, adding an extra drug to the combination would bring on greater toxicity. And another alternative to MVAC was something called dose-dense MVAC, which is essentially the same amount of drug being delivered in half the time. There's about a 1.5 month PFS advantage and similar overall survival. Somewhat counterintuitively, the higher density of chemotherapy was in fact less toxic and was better tolerated by patients. The caveat being that this does require GCSF support because of the pretty significant cytopenias that develop. So this was the overview for the gold standard for first-line therapy for advanced UC. If you were ineligible for cisplatin, and all the previous regimens did involve cisplatin, then you got a different type of chemotherapy. Cisplatin ineligibility has now been codified in clinical trial definition, which is any one of the following characteristics: a creatinine clearance less than 60, also taken as a GFR less than 60. Although I do believe that a lot of medical oncologists will treat patients with a GFR as low as 50 with platinum. ECOG performance status greater than or equal to 2, or a Karnofsky performance score less than about 60 to 70 was also a criteria for exclusion from platinum. And this essentially meant ECOG status 2 is essentially you are able to take care of yourself, but you're not able to do any sort of work activity. Grade 2 or greater hearing loss, grade 2 or greater peripheral neuropathy, and grade 3 or worse heart failure were also exclusion criteria for cisplatin. So if you met any of these criteria, your next best option would be gemcitabine and carboplatin. And this is thought to be oncologically inferior based on several phase 2 trials that were done in the 90s and 2000s. However, carboplatin did have a better toxicity profile than cisplatin. So for that reason, carboplatin is always our not is not the preferred regimen, and we try to give cisplatin whenever possible. And the idea of platinum ineligibility, being ineligible for any sort of platinum therapy at all, even carboplatin, has still yet to be fully defined. And as we're going to see, this is now something that is quite clinically significant because it determines your treatment path. So there have been several criteria proposed, but there's nothing yet completely agreed upon for platinum ineligibility. Most recently, a medical oncology journal proposed creatinine clearance of less than or equal to 30, ECOG status greater than or equal to 3, peripheral neuropathy greater than or equal to 3, or heart failure greater than or equal to class 3. So that is a brief overview and some definitions of how things were before immunotherapy, before specifically checkpoint inhibitors, and in particular within the checkpoint inhibitors, the PD-1 and PD-L1 targeted therapies. And this has really revolutionized the management of advanced UC. And it's really done so in a short period of time. Here's a sort of an abbreviated timeline of the progression of the use of checkpoint inhibitors in humans. So the first checkpoint inhibitor ever approved for human use was Epilimimab, which was approved for metastatic melanoma. And that was in 2011. 4 years later, Urology received its first approval for a checkpoint inhibitor, and Nivolumab was approved for second-line metastatic RCC. This was the first urologic indication. And then the next year after that, Tessalizumab was approved for urothelial cancer, which is the first application of checkpoint inhibitors in UC. And this went on to be the first of 5 approved drugs in the US and 4 in Canada for second-line advanced urothelial cancer. And then most recently, Avelumab has been approved for maintenance therapy after platinum chemotherapy in urothelial cancer. And this is something I'll discuss later, but is really a whole new paradigm in the terms of treating advanced UC. And I think this really goes to illustrate how rapidly the indications and the applications for these drugs are expanding. So now we'll go to talk about first-line therapy. This is a so with IO, we're starting to see a lot of changes in first-line therapy. Initially, it was in second line, as it typically is, and it sort of trickled upwards towards the first line, where we're seeing it now. And we do expect to see a lot of changes even within the next few years. This talk may be obsolete within a couple of years, just with the rate that things are changing. This table is from a recent COA review article published a couple of months ago by Dr. Black, among others. And we're just going to sort of do an overview here before we dive into the evidence. So overall, if you have advanced UC, your treatment is determined by your platinum eligibility. So if you're eligible for cisplatin, this is still the gold standard, at least for now. And gemcitabine cisplatin is your go-to. However, if you are ineligible for cisplatin, then this is where things start to get a little bit tricky. If your tumor is positive for PD-L1, then you're eligible for IO. If your tumor is negative for PD-L1, then you're only eligible for gemcitabine cisplatin or carboplatin. Now, when I talk about PD-L1 positive and negative in this study, it's not really a uniform definition. Right now, the different trials have their own proprietary assays for PD-L1 expression and their own definitions for what constitutes positive and negative. So it really is not a single unified definition, and it really depends on which drug you're talking about. So do keep that in mind as we talk. So as we can see now, for someone who is ineligible for cisplatin, and as we know that is a lot of our patients, the PD-L1 status matters a lot, which is why now for those who are cisplatin ineligible, the algorithm proposed by Black et al. Is to do a PD-L1 assay on everybody on their tumor to determine whether or not they would be eligible for IO if they're not eligible for cisplatin. And then finally, for those who are ineligible for any sort of platinum, they get IO. mostly because their other options are so poor. We'll touch on this later, but FGFR gene alteration assays are now recommended for anyone who has advanced UC because of the potential applicability of FGFR targeted therapies currently in the second line, but likely soon in the first line as well. So everyone should get tested for this because the drugs can have a significant effect if you have the right alterations. So we're going to focus now on the cisplatin ineligible population. This is a study of Pembrolizumab in the first line in patients who are ineligible for cisplatin. And this is typically, the cisplatin ineligible population is typically the way in which drugs enter into the first line because the alternative to cisplatin is inferior, as we'll discuss. So Pembrolizumab was given in this phase 2 single-arm trial to about 375 patients who were ineligible for cisplatin. They got Pembrolizumab every 3 weeks, and the primary outcome was overall response rate. The response rate was 24%, and this ranged from 10% in the lowest PD-L1 expression group to 38% in the highest PD-L1 expression group. And 5% of patients had a complete response, meaning that they had no evidence of residual disease. The median follow-up in the study was 5 months, and during that time, the median response duration was not met. 78% of patients, however, had a response duration that lasted greater than 6 months, which is sort of a theme that we'll see with IO, in that if you do develop a response, you tend to develop quite a robust response. And overall, the Pembro was quite tolerable, with only 16% of patients having adverse effects of grade 3 or worse. So this is a second study in a similar setting, this time for Tessalizumab, IMvigor210. And this is also a phase 2 single-arm trial. It was a bit smaller, with only 123 patients compared to the Pembro trial. They received the Tessalizumab every 3 weeks. And in this study, they stratified testing by PD-L1 status. And they did a hierarchical statistical design, meaning that they had their first outcome that they tested, and if that was statistically significant, then they could test their next outcome, and so on and so forth. The caveat being that the first time you had a non-significant result, you could no longer proceed down the chain of statistical testing. So unfortunately for this trial, at their time of analysis, the response rates were not significantly higher than the 10% benchmark that they had set. So although overall response rate was 22% in the highest PD-L1 expression group, this was not significant. And so unfortunately, they couldn't do any more statistical testing because of the study design. However, they did sort of follow this up with some post-hoc exploratory analyses. And eventually, more people responded later, which is also something that's seen in IO, in that patients tend to respond late, and they can develop late responses quite far out from the initiation of treatment. And then with these additional responses, the response rate became significant. However, because by trial design, they couldn't test this formally, it's just an exploratory analysis. Response duration was quite good, like with Pembro. 70% of responses were ongoing at 17 months of median follow-up. Tolerability, again, was quite good as well, with only 16% having a grade 3 or worse treatment-related adverse event. So this is the table that just compares Pembro and Tessalizumab to first-line cisplatin. The IOs are phase 2 trials, so it's and their primary outcome was not overall survival, so it's hard to make a direct comparison there. But I think the main takeaway is that the response rates for IO were about 25% compared to 45 to 50% for cisplatin. So you can see why cisplatin is still favored when you can get it. However, the tolerability for the IO regimens was a lot better than cisplatin. So we'll see that based on this data, as well as some early phase 3 data that we're about to review, the FDA approved Pembro and Atezo for first-line cisplatin ineligible patients, only if they are positive for PD-L1. Health Canada has approved Pembro for this indication, but not Tessalizumab. This leads us back to our treatment algorithm. We can see that testing PD-L1 is important in patients because it determines in a cisplatin-ineligible patient whether or not you're eligible for IO or whether you receive gemcitabine and carboplatin, which is inferior. This is a study of a new combination of platinum and immunotherapy in the first line. And this was a phase 3 RCT of Tessalizumab. Patients could not have had any prior systemic therapy, and they had to be ineligible for platinum. They enrolled over 1,000 patients and randomized them to one of three arms. The first group was a combination of Tessalizumab and platinum. The second group was Tessalizumab only, and the third was platinum only. In this study, 2/3 of patients received carboplatin, of which 40% were actually eligible for cisplatin. So that's something to keep in mind in the study, is that it may not necessarily be applicable to the wider population. The co-primary outcomes for the study were PFS and overall survival. So PFS was one of the co-primary endpoints here, and this is shown here in final analysis. There was a modest PFS benefit of about 2 months, with a combination at 8.2 months of progression-free survival versus 6.3 for platinum. Hazard ratio for progression was 0.82, and there was a similar effect across all subgroups, and there was not a significant differentiation based on PD-L1 status or which type of chemotherapy you got. The other co-primary was overall survival, which did not show a significant difference. However, it is important to note that this is an interim analysis, and there was a numerical advantage to the combination therapy regimen. And with more time, we may see this sort of tip into statistical significance once the data fully matures. If we look at the Kaplan-Meier curves on the left, you can sort of see a separation beginning to develop between Tessalizumab and between the combination and platinum, and you wonder if this will end up being significant after more follow-up. This is a comparison of the group B, which is Tessalizumab only versus platinum alone. And there was not a significant benefit to survival here. There was a numerical advantage overall to Tessalizumab, but this was not significant. If you look at the curves, actually, the platinum patients did better in the first 9 months, and only at about 10 or 11 months does Tessalizumab achieve equivalency in terms of overall survival. Going further, these two curves show the Tessalizumab only arm versus platinum, but when stratified by PD-L1 status. So on the left, are the PD-L1 positive patients, and on the right are the PD-L1 negative patients. And you can see that immunotherapy is better than platinum in PD-L1 positive patients, but not in PD-L1 negative patients. And in fact, the platinum patients do significantly better than Tessalizumab only. And so for this reason that the FDA made the decision to approve immunotherapy for cisplatin-ineligible patients only if they were PD-L1 positive. Looking at adverse events for the combination regimen versus the monotherapy arms, the IO plus chemo arm was comparable to the chemo arm. The combination had an 83% rate of grade 3 or worse adverse events compared to 85% for platinum alone. 82% for platinum alone. And IO monotherapy was significantly better than either of them, with 16% rate of grade 3 or worse adverse events. So there was also, of course, the study of Pembrolizumab in the same population. Again, this is a phase 3 controlled trial, 1,000 patients with Pembro and platinum combined versus Pembro alone versus platinum alone. 55% of these patients received carboplatin, and the co-primary outcomes were PFS and OS. There was no significant difference in progression-free survival in this trial. And furthermore, there was no significant benefit in overall survival either. This was a negative study, which was quite surprising and somewhat disappointing as well, given the fact that there had been some benefits seen in the Tessalizumab. In terms of adverse effect profile, Pembro patients who received Pembro alone seem to do worse in this group with 63% adverse event ratio rate versus 87% for the combination and 82% for platinum alone. So to put this again into treatment or into our treatment algorithm, the combination of IO and chemotherapy would potentially replace GemCis as the first-line management. Unfortunately, the data for this has not really panned out so far. As we saw, the Atezo study showed a very modest PFS benefit, about 2 months, and a non-significant overall survival benefit, which may change with more follow-up. And the Pembro study was negative. So overall, it appears as if combination therapy is on the back burner for now, but it may resurface down the line. I want to talk now about Avelumab, about IO maintenance therapy, which is really an exciting new paradigm in management of advanced UC. So this trial, Javelin 100, looked at Avelumab as maintenance. It was a phase 3 trial, randomized, open label with 700 patients. And it looked at patients who were receiving cisplatin or carboplatin and gemcitabine, and who did not show any signs of progression after completing their initial cycles. In this trial, about half got cisplatin and about half got carboplatin. And the patients were randomized to either Avelumab every 2 weeks or supportive care. And they were followed until progression, withdrawal, or death. The primary endpoint was overall survival. There was a significant benefit to maintenance with Avelumab. 7 months for survival overall, with a hazard ratio for death of 0.69. You can see here from the Kaplan-Meier curves, there's quite a significant early separation between the Avelumab arm in blue and supportive care only in red. The benefit became even more pronounced in the PD-L1 population, or PD-L1 positive population, with overall survival not even being reached by the end of follow-up, and hazard ratio for death dropping to 0.56. Again, there was also a PFS benefit, 1.7 months versus 3.6 months in the PD-L1 positive group. I'm sorry, 1.7 months overall, and then this increased again to 3.6 months in the PD-L1 positive group. The maintenance of Avelumab was quite tolerable, with grade 3 or greater adverse events being 47% in Avelumab versus 25% in the supportive care arm. Only 12% of these adverse events actually led to patients discontinuing Avelumab, which goes to show you that it was quite tolerable overall. Similarly, there was a trial of Pembrolizumab in the same setting as maintenance. This is a phase 2 open label trial with 100 patients, so quite a bit smaller. And these again were patients who didn't progress on platinum. They had Pembrolizumab every 3 weeks versus placebo for up to 2 years. The important difference here is that in this trial, the patients who received patients who received placebo were allowed to cross over and receive Pembrolizumab when they progressed, meaning that it was more a comparison of upfront Pembrolizumab maintenance versus delayed Avelumab or Pembrolizumab maintenance. And we were looking at PFS primarily in this population. So there was a PFS benefit, 5.4 months versus 3 months for the Pembrolizumab maintenance arm, but there was no overall survival benefit. Grade 3 or worse adverse events were 60% for Pembro versus 38% for placebo. So comparing the Avelumab and the Pembrolizumab maintenance trials, it may seem like a bit of a disappointing result for Pembrolizumab because there was no overall survival benefit. However, we do have to consider that there's a different context here. Both drugs actually had similar overall survival lengths, 21.4 months in Avelumab versus 21.4 months in Pembrolizumab. But the control group in the Pembro trial did significantly better than those on Avelumab. And that may have been because the patients in the Pembro trial were allowed to cross over if they got placebo. So they would have presumably reaped some of the benefits of Pembrolizumab maintenance. So the idea of starting induction systemic therapy with one agent and then switching to a different class for maintenance therapy is called switch maintenance. And this has not previously been used in urothelial cancer. So it's really quite a revolutionary idea, and it's quite exciting. The FDA has already approved avelumab for maintenance therapy, but Health Canada has not. So we can see here, as fitting it into our algorithm, you would potentially receive avelumab after receiving cisplatin chemo. So for those who received Gem-Cis and for those who received carboplatin and gemcitabine, you would, in theory, be eligible for avelumab maintenance afterwards. There are a lot of unanswered questions right now in terms of how this would be applied and how it would interact or compare to patients who received first-line immunotherapy, but there is a lot of research ongoing in this area.
Matt, can I say something there, just on that slide? You've talked a lot about IO therapy for PD-L1 positive, platinum ineligible. It's not actually accessible in Canada, even though it's approved. It's not accessible, so that doesn't actually happen. And now that you have phase 3 data with avelumab maintenance, that probably would totally disappear, because you would want the patients to get, if they're carbo eligible, you would want them to get carbo so they could then go on to avelumab as a maintenance therapy. So that would probably be the preferred route. And this whole box of giving IO for the PD-L1 positive cisplatin ineligible would probably disappear.
I see. So you'd prefer just to give them carbo and then avelumab maintenance than upfront IO?
Because it's phase 3 data, more robust data.
Right. That makes a lot of sense. Okay. So that's our talk about the first line. So now we're going to go on to second line therapy, which is primarily IO or Fgfr targeted therapy, which is another interesting new development in the field. So historically, second line therapy after progression on first line platinum was, the answer for that was more chemotherapy. And your options there were platinum again, or taxanes, or vinflunine. As you can imagine, patients who are metastatic urothelial cancer, who have already progressed on the first line of chemo, are typically not well patients. And giving them more chemotherapy is typically not something that is going to be very successful. So historically, 1/3 of patients who received first-line therapy and progressed ended up receiving second-line therapy. So that means 66% were going essentially into palliative. So the outcomes for these patients who did receive second-line therapy were also, understandably quite poor, with survival typically being less than a year. This is why the advent of immunotherapy in this population was very much a breakthrough, because it came with the promise of greater efficacy and significantly less toxicity, meaning a lot more accessibility for patients who had progressed on chemotherapy. So there are 4 approved PD or PD-L1 inhibitors in the second line in Canada: Pembrolizumab, Tessalizumab, avelumab, and durvalumab. We're going to focus primarily on Pembro and Tessalizumab because these are the 2 that have phase 3 evidence right now. So Pembro was the first. Pembro was not the first, but Pembro was is the main one used, and this was a phase 3 randomized controlled trial with 750 patients. All these patients had progressed on first line platinum, or had progressed within 12 months of receiving either neoadjuvant platinum or adjuvant platinum. And they were randomized to either Pembrolizumab versus an investigator's choice of chemotherapy, which included taxanes or vinflunine. And the primary outcome study here was overall survival. So there was a significant overall survival benefit, and this remained robust on extended follow-up, which was published last year. Overall survival for the Pembrolizumab arm was 10.3 months compared to 7.3 months for the chemotherapy group. In other terms, at 1 year, 44% on Pembro were alive compared to 31% on regular chemo. And the benefit to Pembrolizumab was observed consistently across all subgroups, including PD-L1 expression and the type of chemotherapy that was received. The response rate was 21% in the Pembro arm versus 11% in the chemo arm. And 9% of patients developed a complete response, which is notable because, as we've discussed, the patients who do respond to pembrolizumab tend to have, or the patients who respond to IO tend to have a pretty durable response, meaning that after having progressed on first-line chemotherapy, you could receive a drug that would render you essentially free of disease for a year or more. And this is quite exciting at the time. Response duration, as we've seen, was not reached in this trial for Pembro trial for Pembro versus 4.4 months for chemo, and about 70% of responses were durable at a year. And of course, the adverse events were significantly better in Pembro at 15% versus about 50% for the chemotherapies. So similarly, Tessalizumab really seems that where Pembro goes, Tessalizumab goes. There was a similar trial for Tessalizumab in the second line. This was a phase 3 randomized controlled trial as well, with 930 patients, again, who progressed on first-line platinum or within the year of perioperative platinum. The randomization was to Tessalizumab versus the investigator's choice of taxanes or vinflunine. And this study primarily looked at overall survival first in the PD-L1 positive group. So they really wanted to focus in on the group that they thought would be the most likely to respond well. So unexpectedly here, there was no overall survival benefit in the PD-L1 positive population for Tessalizumab. This is in contrast to prior phase 1 and 2 data that had been published on Tessalizumab in this setting. And it was really quite surprising to the investigators. And because of the hierarchical trial design, because the first outcome tested was negative, they could not test any further comparisons. So it was essentially a negative trial, even though the overall survival in this study was numerically superior. It is not enough to be statistically significant, and we can sort of see that in the Kaplan-Meier curves. There does look to be a separation of the curves, but at the time of the termination of the trial, it was not sufficient. So although they couldn't make any conclusions about this, the investigators did observe that the 95% confidence intervals for PFS did not overlap. So they postulated a PFS benefit in the intention to treat group. And there was a longer response duration in Tessalizumab at 16 months versus 18 months. So although this trial was ultimately a negative trial, we can see that the overall survival in this study is actually comparable to what it was in the Pembro trial. And Tessalizumab, I believe, is still approved for second-line therapy, at least in Canada. And then just to round out the discussion on second-line therapies, Avelumab and Durvalumab have both been studied in phase 1 and phase 1 or 2. And the response rates are 16.5% for Avelumab and 17.8% for Durvalumab. So now I want to talk about FGFR targeted therapy. And Dr. Black did a very extensive rounds on this last year. And so I'm not going to dive too far into it. But Ertafitnib has been trialed in phase 2, and the results were published last year. And this was given to patients with advanced UC who had specific mutations or fusions in the FGFR receptor. And these patients who had progressed on chemotherapy first line or who were ineligible for cisplatin received Ertafitnib. So of the approximately 500 patients that they screened, only 21% of patients had the suitable mutations that made them eligible to receive Ertafitnib, which is somewhat of a proxy of the overall prevalence in the population. So overall, they gave the drug to 99 patients, and they looked at response rate. So response rate was quite good at 40%, and this increased to 60% in patients who had previously received immunotherapy, which is something that will maybe become important later. The duration of response was 5.6 months. Overall survival, which is not a primary outcome, but was estimated, was about 14 months, and PFS was 5.5 months. Grade 3 or worse treatment-related adverse events, 46%, primarily stomatitis, hyponatremia, and nail dystrophy. This table compares the results posted by the different studies in second line. So Pembro, Atezo, and Ertafitnib. Do keep in mind that Ertafitnib is a phase 2 trial, and there's a phase 3 trial pending, which will hopefully confirm these results, and which also compares Ertafitnib directly to Pembro, which will be quite useful. So because Ertafitnib is a phase 2 trial, it's difficult to compare the overall survival and PFS. But the biggest story is the overall response rate, which at 40% for Ertafitnib was significantly higher than Pembro or Tessalizumab in this disease space. The caveat to this, of course, is that in order to receive Ertafitnib, you need to have a suitable Fgfr alteration, which, as we saw, was roughly 21% prevalence. Pembro and Tessalizumab had a longer median response duration than Ertafitnib, which is consistent with the idea that with IO, that if you do get a response, if you're one of the minority that does get a response, your response tends to be very, very good. So before we look at the algorithm for second-line therapy, let's just review for the first line one more time. Essentially, if you are PD-L1 positive and you're ineligible for cisplatin, or if you're ineligible for platinum altogether, you could get IO. But as Dr. Black brought up, perhaps in this group, if you're ineligible for cisplatin, you would rather get carbo and avelumab maintenance. If you do get platinum, you're eligible for avelumab maintenance. With the phase 3, with the excellent phase 3 outcomes that we've seen, that we discussed, that's really a desirable place to be, I think. So this is now the algorithm for the second line. And really it's divided into whether or not you have already received immunotherapy. So in those who are IO naive and who don't have an eligible mutation, the choice is obvious. They get immunotherapy. In those who haven't gotten IO but are eligible for Ertafitnib, there is a choice between IO versus Erta. Now, recall that in that Ertafitnib study, the response rate increased from 40 to 60% when patients had received IO previously. Obviously, that's not enough to base a treatment decision upon, but it suggests that perhaps patients who get IO first will do better getting IO second, which is perhaps a consideration to make going forward. In patients who have received IO and who have progressed already, the choices are chemotherapy or FGFR therapy. Clearly, I think if Ertafitnib is an option here, that would be your choice because it appears to be a lot more effective and a lot less morbid than chemo. So finally, we're going to talk about third-line therapies. And in here, we're going to have some discussion of some experimental things that look to be coming down the pipeline quite quickly. So third-line therapy mainly involves trying any of the previous options that a patient has not yet had. However, there is a new drug that's currently being considered for Health Canada approval, which shows some very, very promising results, and is called enfortumab vedotin. This is an antibody drug conjugate. The antibody portion targets Nectin-4, which is a cellular adhesion molecule. This is highly expressed in several different malignancies, including urothelial cancer. And it's also expressed in normal skin. So this antibody is coupled to monomethyl auristatin E, which is a very potent microtubule inhibitor that's normally too toxic to be used alone in humans. So the combination drug binds to Nectin-4 on cells, and then the drug is endocytosed, whereupon the payload is released and there is a targeted killing effect, which is preferential for Nectin-4 positive cells. So enfortumab has shown very promising results in phase 2 trials, which led to it being approved by the FDA, likely with Health Canada approval coming soon. So in this trial, EV201, 125 patients who had progressed already on platinum and on immunotherapy got enfortumab vedotin. There was no limit on how many prior lines of therapy these patients could have gotten. And on the median was 3 prior lines of systemic therapy. So as you can see, these patients had very aggressive, very advanced disease. 90% had visceral metastases, 40% had liver metastases already, which is really one of the worst prognostic factors you can have in advanced UC. And the primary outcome in these patients was overall response rate. And the response rate was 44%, which was quite excellent, honestly, for this population with such advanced disease. There was a 12% complete response rate. And that's quite remarkable if you imagine a patient having progressed on everything you've given them so far. On average, 3 lines of treatment they've progressed on, and all of a sudden they receive this drug and their disease melts away to nothing. And the duration of response was quite good as well, 7.6 months, which was, again, for this population, longer than their life expectancy in most cases. And overall survival estimated, it was not a primary outcome for this trial, was 11.7 months. And you can see here the swimmers plot on the left showing patients with an ongoing response at the time of termination of the study was quite good. In terms of toxicities, 54% of patients had a grade 3 or worse treatment-related adverse event. The most common severe adverse events were fatigue, peripheral neuropathy, nausea, diarrhea, and rash. Do you remember that Nectin-4, which is targeted by this drug, does get expressed in the skin normally as well? So you would expect to see some skin manifestations in the adverse events. In just about a month ago, there was a press release for the phase 3 confirmatory study of enfortumab. And this revealed that the phase 3 RCT for enfortumab had met its primary OS endpoint and its secondary PFS endpoint. And so they were crossing over patients now from the control arm to the treatment arm and essentially wrapping up the study. So right now, at least, this is our algorithm for the management of advanced UC, and it's changed quite a bit compared to even when I started residency. And I expect in the next 4.5 years that this landscape will look completely different as well, and probably a lot of these things will be the treatment will be completely different. So really, it's quite an exciting time to be involved in oncology in general, but also in urothelial cancer. So again, just to review, in the first line, you can get platinum if you're eligible for it, and that's the preference at this point. And ideally, you'll get cisplatin. If ineligible for cisplatin and positive for PD-L1, then Pembro or Tessalizumab are your options, or perhaps gemcitabine and carbo, followed by avelumab maintenance. In the second line, if you haven't had IO already, you can receive that. If you have a suitable Fgfr mutation, then you can also receive Ertafitnib. If you aren't eligible for either Ertafitnib or IO, then you can get taxanes or vinflunine as chemotherapy. There is pending approval for enfortumab in the third line, and you wonder whether or not enfortumab, if approved, would be brought up into the second line relatively rapidly for patients who are not eligible for chemo, who are not eligible for IO or Fgfr patients or Fgfr. And then finally, again, in the third line, essentially you just try whatever hasn't been tried before. Enfortumab is coming in this disease space, and soon we may see combinations of enfortumab and IO. In fact, there's a trial that I didn't include in this presentation that looked at Pembro plus enfortumab and that had really, really good responses and good overall survival, but that's still to come. So that concludes my talk. Thank you for listening. I'm happy to take any questions.